live.
Good morning.
Well, good morning, everybody. We are here in the Hamot boardroom, and thank you all for joining us in what we're all calling these unprecedented times. I am joined over my left shoulder by Charles Hamot Strong, so we figured it would be appropriate for you to see our founder during all this. And we have a great agenda for you, and I want to thank all of you for joining us today. I'll give a few brief comments. David Gibbons will fill you in on just the wonderful work that his team is doing in terms of preparedness for COVID. We have a very special guest today, and Dr. Derek Angus, and Dr. Angus will share with you what the brilliant scientists at UPMC and Pitt are doing, not just to assist our community and our region and our state and our country, but really it's global work that they're doing. So we're anxious to share all that with you. And then throughout the course of our meeting today, feel free to submit questions and type them in as they come to you. And at the very end, we'll have Dr. Angus and David answer some of those questions for you. We'll also be joined by Dr. Greg Beard, our Vice President of Medical Affairs, and Emily Shears, who's done a fantastic job, and you've probably seen her on television with Kathy Dahlkemper, and Emily runs our infection control department, has done great work through all this. So before we get into that, just want to give you a few updates on the Hamot Health Foundation. I think the word that we all use frequently is pivoting, and our foundation, like every organization, has pivoted. And in the first week, I want to thank our board and our leadership. Our board put up upwards of $1 million to help this hospital in the immediate need with COVID-19. If that meant help with capital needs for our collection centers and or PPE or whatever this hospital and our heroes needed, the foundation has been here for them and will continue to do that. Very small things, but to very big things. A concrete example of something that I think is a very unique, and you'll hopefully be hearing more about this, but we have great friends at the Erie Playhouse, and Kate Lechner and Charlie Corritori. If you're at our gala, you saw the great work that they did with the Hamilton spinoff. But also, they're at a time where their theater's dark, but they have volunteers who make great costumes, and in fact, they have no costumes to make right now. So our foundation is supporting them and sponsoring them, and they're making cloth masks because we all know masks are going to be part of the norm for all of us. So first delivery will come today, and we'll make sure those masks get distributed in areas of our community that need it most. So we are very thankful for them and the great work that they're doing. And that's just one of many things that we're doing, providing meals for frontline workers, not just in the hospital, but in the fire department, in the police department. Tomorrow and today and tomorrow, we're donating meals to the Erie Homes for Children and Adults. Those are heroic workers who are taking care of their residents day in and day out. And we're partnering with Chuck Walzak and Jonathan Rilling and their team there. So just a lot of good things going on, and just a small plug in the fact that our Hamot Strong event would have been Saturday, and of course we cannot have that, but it's a virtual auction that's going on as we speak. We're probably pushing the $20,000 mark in the first day, and we're very happy about that. Those are scholarships to support what our team has already awarded just in the last couple of weeks, is nearly $200,000 in scholarships to 90 of our employees who will continue their education. We're calling it Hamot Stronger, and I think you get what we're saying there, but we have been Hamot Strong. We always are Hamot Strong, but this team has stepped up in ways that we are extremely proud of all the work they're doing at the foundation. We're extremely proud to support everybody. So as we move on with questions, I want you to know that at the Hamot Health Foundation, we're not running in place. We are moving forward. Our McGee project is going very well. Our corporate project is strong and continues to be strong. And you'll be hearing a lot more from us. So as I always say jokingly in front of you, when you see emails from Boo Haggerty, don't delete them. So we'll have some great things to continue to tell you. But with that, very proud today to introduce our president of the hospital, David Gibbons. David has been 7 days a week for multiple weeks now. He can tell you they're probably all running together, but doing a great job of leading your hospital. And David, it's up to you to take it from here.
Yeah.
Okay, Boo, thank you, and I thank everyone for support. The Hamot Health Foundation Yeah, sorry, technical difficulty. The Hamot Health Foundation has really, we are family. We were not even partners. We are family, and I don't think we have felt that any more than really during this time. At the beginning of this journey, everyone was truly frightened, myself included. And today we are certainly in a much different place. If anyone ever questioned the strength of UPMC, our response to this pandemic dispel those doubts. And I, along with my executive colleagues, continue to receive praise and recognition from employees, from the medical staff and professionals throughout the United States, citing and recognizing UPMC's swift response, their organization, and truly their commitment to the employee and patient safety. 6 weeks ago, there was worldwide panic regarding the shortage of personal protective equipment, or as we say, PPE. The Hamot Health Foundation Board of Directors approved an unprecedented emergency grant to UPMC Hamot for the sum of $900,000. And the intent of this grant was to enable Hamot to act expeditiously to purchase PPE. Everyone across the world was scrambling for PPE, and they wanted us to be prepared without any restriction or limitation to act upon those opportunities with swift force. And it positioned us very well. We were and we continue to be moved by the powerful act to provide Hamot's workforce with PPE, and the intention of this grant all along was to protect our valuable workforce, truly moving and really resonated throughout the entire hospital. There have been numerous local initiatives that have been implemented during the past 6 weeks, and I'll highlight a few of those for you. We began with restricting access. So we limited the entrances and exits to the hospital, to the emergency room, to the main entrance of the South Tower, the main entrance of the hospital, and the women's hospital entrance. These seem like easy things to do, but in healthcare, nothing is ever easy. They were complex and required a great deal of planning. Restricting ID badge access to these areas across over 3,500 employees is no small feat. We also then moved into a restriction of visitors. So we implemented a plan and continue to fine-tune that throughout this journey. And we also encouraged staff to wear masks. We provided masks, and then we moved into a mandatory wearing of masks in clinical areas, public areas, etc. UPMC has and continues to provide surgical masks to staff and the limited visitors who are permitted to enter the hospital. One of the other major accomplishments is not only a proud moment for UPMC, but certainly a very proud and prideful moment for the community. In 1 week, we constructed and opened a collection center in the Lear building, which was nothing more than a cement floored storage unit. And not only did we open this collection center, but it is an environment that is a negative airflow environment, which is the safest environment for staff and for patients, adhering to the CDC guidelines. We also opened our emergency command center. So we've been running that command center 7 days a week now. And they are the center of all COVID activities for UPMC Hamot, and they are linked to the system and they are linked to the community. In addition, the system opened their emergency command center, and Hamot participates on daily calls, and sometimes even more frequent than that, with reports to the system command center from number of COVID cases to reporting on our supply of personal protective equipment. It's been very, very powerful and extremely organized. Under governor's order, we closed our surgery center across the street, so that continues to remain closed. And again, how intricate this is in coordinating care, because we Hamot is the second busiest surgery center, ambulatory surgery center in the state of Pennsylvania. So you can imagine the work that's involved from Dr. Beard and his team to coordinate surgeries and consolidate those into the main hospital. We converted 3 nursing units in the hospital, 5 South, 5 Main, and our medical ICU. We added new entrances to those units. We limited access to only a very select few for safety, and those units were and are the COVID units. So in the event that we receive a patient who is COVID positive or a patient that we suspect might be COVID positive, we place those patients into those units, all of which are negative airflow units. It's not 1 room or 2 rooms. Those are the entire units. So with 70+ beds that are in a negative airflow environment, again, is a monumental feat and adhering to the highest level of safety under the CDC guidelines. That has been our focus, and that will continue to be our focus during this time. We also commissioned and validated a Cepheid analyzer, which is an analyzer that can perform rapid testing. We use that for patients that are in-house. And in a 1-week period, our phenomenal laboratory team under the direction of Dr. Dopowski commissioned this equipment, validated the analyzer so that it is safely analyzing COVID-19 testing. Which leads me into UPMC has been and continues to be a pioneer and a global leader in clinical research and practice, including COVID-19. In early March, we announced the discovery of a COVID-19 test. Next, UPMC announced the discovery of a COVID-19 vaccine. Not relying on vendors or scientists, we began creating testing swabs, vials, the list went on. And simply stated, our goal is to test all patients. In addition to these monumental discoveries, UPMC's recent announcement really is regarding for us to revolutionize the world's COVID-19 research stage with a process called REMAP. And today I have the pleasure to introduce to you Dr. Derek Angus. I've worked with Derek, I believe, since probably 2009, or when he joined, 2009, and through critical care medicine. Derek is a distinguished professor. He is the chair of the Department of Critical Care Medicine of both the University of Pittsburgh School of Medicine and the UPMC healthcare system. So it is my distinct honor now to introduce Dr. Angus.
David, thank you very much. I'm just checking folks can hear me okay. All right, I'll presume you can. So yeah, I'll talk to you a little bit about REMAPs, but let me just first of all start by saying that from the Pittsburgh end of things, as we were getting ready for the preparation, I would echo everything that that David had said. Right from the beginning, leadership in critical care, in hospital operations and emergency medicine and infection control had put together a system-wide sort of command center, and that included an inpatient clinical operations center who were trying to think about how we would reorganize hospitals. And we had this notion of having a philosophy about what we wanted to do system-wide, but then really local execution within each hospital. And in that, there was already strong relationships among all the hospitals, but it was really amazing how well all the VPMAs, the Vice President for Medical Affairs and Chief Nursing Officers from all of the system came together. And so Greg Beard and his team at Hamot have been fantastic to work with. I think the other thing I would say is, before getting to research, another thing that was very much on people's mind was what would happen if we really got into trouble and we began to be facing hard choices about allocation. And in that too, UPMC really felt like it should be thinking at the system or the regional level. And so there was an effort by UPMC led by Doug White to look at our allocation plan, look at the ethics of it, make sure that it made sense for COVID-19. And some of you may be aware, but the UPMC resource allocation plan for COVID-19 then caught the attention of Governor Wolf. And so they asked UPMC to write the allocation plan for the entire state. And so UPMC's plan became Pennsylvania's plan. It's now been adopted by hundreds of hospitals across the country and by multiple states, and has ended up being written up in the New York Times and so on. So that would just be one more example of the way in which UPMC really tried to move fast to think through all eventualities in COVID-19, including what would we do if things became really dire. Okay, so let me pivot slightly. So everyone knows that there is no active treatment for COVID-19. So we can bring patients into the hospital, we can watch them carefully, and if they can get sick, we can put them in the ICU and we can put them on supportive care, on ventilators and so forth. But there's no treatment that tackles either the virus itself or the way the human host mounts a response to the virus. And so you see that, for example, when President Trump gives a White House briefing and says, I think we should maybe try to give everyone hydroxychloroquine. And then Tony Fauci says, or we should test hydroxychloroquine. And what goes on in that moment is that both are right. There's a compelling desire to treat patients with whatever we can. And yet at the same time, there's a real need to try to discover as fast as possible what's the best treatment. So UPMC actually has these two goals. They want to simultaneously provide the best care tomorrow, the best care today, and as fast as possible discover new treatments for tomorrow. So that's in a way wanting to both do and learn. And we had already been thinking about this idea of how can you do both simultaneously, so-called learning while doing. And the reason that might sound like a cute phrase, but normally the way the world works, it's almost two separate worlds. There are people taking care of patients, and then there's researchers in a lab, and they almost have different goals and incentives. They're employed by different organizations. Medicare pays for care, and the NIH pays for research. And what ends up happening is that these sound like similar goals, but they can sometimes be in competition with each other. And that tension, if you like, was what was in the middle of that press conference with Fauci and Trump, where both are actually correct, but they seem almost like goals that you can't reconcile. So we at UPMC had been interested in trying to solve the joint goals by thinking about study designs that allow us to learn while at the same time also leaning into patient care. And that meant thinking about things like, for example, not having everyone be 50-50 to placebo or treatment, where then half of the patients, it feels like it's a random chance and they could just be a guinea pig. And so we had already started work ahead of time on the idea of so-called Bayesian adaptive platform trials, and a particular type called a REMAP. Now that's a mouthful, but it stands for randomized, so we're still randomizing patients. Embedded, where we try to embed in the care process. A multifactorial, and I'll get to that in a minute. That means basically testing multiple interventions at the same time. Doing so all in an adaptive way, and I'll explain what that means too, and then doing it on a platform, so a REMAP. No one needs to remember that acronym, or they don't need to remember what it stands for, just go with the concept of REMAP. So we had already led an international consortium to think about using a REMAP designed to learn in a pandemic, and had already helped lead what had been set up in other countries, but wasn't here. And then as about 6 weeks ago, when UPMC and the rest of the United States had to start suddenly thinking about what was happening, just as fast as we were thinking about getting ready for the clinical care, we started asking ourselves, how could we bring a remap design for testing different therapies for COVID-19 patients to the entire UPMC system? And so we joined forces with a trial that we were already running internationally, but decided to work out how we would embed it across our entire system. And so we built all the infrastructure for the trial into our electronic health record, and then thought through how we could even have video links for doing consenting of patients, so that if any patient hit anywhere in the system, they could be entered into the trial. Now, what's unusual about the trial is that it's not just one drug at a time. It's like going to a restaurant and choosing a starter, a main course, and a dessert from multiple options all at the same time. And so we can test antivirals, steroids, immune modulators, convalescent serum, all at the same time. And so then they end up becoming multiple recipes, only one of which is just standard care. So standard care is only a tiny fraction. It's not 50-50. And then furthermore, the trial sends all the data to one common data center that's then running a machine learning algorithm that updates over time, even while the trial is running. So it's like getting to keep rebetting on the horses that are doing best in the race. And so patients, as they come in over time, get preferentially assigned to the best performing therapies. So that whole thing went from not existing to within 3 or 4 weeks being IRB approved, set up by our IT folks throughout the system, along with our command center down in Oakland, being staffed 24/7 by both physicians and clinical research staff to help walk through by video link with patients or their family members the consenting process. So the trial got IRB approval about a week or so ago, and thankfully we don't have too many patients coming into the system right now, but we're now enrolling patients all across the system. Now, we haven't enrolled a patient at Hamot yet, but we've enrolled patients at places like McKeesport or hospitals that have never done clinical research before. And indeed, the Associated Press came up and filmed us doing this video consent of a patient at McKeesport, and is going to continue to follow the patient. So you're probably asking, well, what works? And I'm going to tell you before you ask, I have no idea. Part of the reason we're doing this strategy is because we want to test multiple combinations. There's many different antivirals. There's obviously hydroxychloroquine that everyone talks about. So we're testing that. We're testing steroids. We are rolling out convalescent serum. Just as soon as our IRB gives us approval, we've already got convalescent serum for about 10 patients that we can treat. And I know that the Hamot blood bank is very much part of this as well. And then we have a whole laundry list of other interventions that we will be spooling through. And anytime, the whole trial is learning from everyone else. So if a patient arrives tomorrow at Hamot, they're essentially, the algorithm is learning and can bring the weighted likelihood of getting the best performing therapy based on patients that were enrolled in London, Sydney, Amsterdam, and Toronto. So with that, I'll stop talking, but suffice it to say, this really fits with our vision for really moving into this idea of having a true learning health system. It's the whole system. It's all engaged in bringing innovative therapies, and it leverages a lot the fact that there's already such great person-to-person communication across the system. The people are very vested in the notion of it being one system, and the infrastructure, the IT infrastructure has made this absolutely essential. Could not have happened without it. With that, I'm happy to take questions.
Dr. Angus, thank you very much. In as much that you are one of the busiest people we know right now in the system, and the fact that you gave us some of your time today to share your expertise with the community. We're very, very grateful for that. So as people online would like, they can submit their questions. Not a lot are coming in, because I think you do such a remarkable job of making lay people like us really understand pretty complex work that you are doing. I like the menu analogy, so I'm actually going to start to have my salad, my entree, and my dessert all at the same time. So I think that's I've learned something from that. But one of the questions that we have received in terms of the length of this, so many of our community members are asking us, when will this end? When is this going to go away? And obviously no one really has the true answer to that, but how would you help us to answer to our community, who Erie County hasn't seen a lot of cases and the community is anxious to open back up? And I know there's that debate between government and the economists and the health officials as to what to do. But, how are you answering that question, and what's the best way for us to address our community at this point? I can leave that for everybody as well. So. Sure.
So, so there's a huge part of this disease that's barely a disease at all. A huge number of patients are going to be asymptomatic. Because we've not had enough test kits, we haven't really been able to do population level sampling among people who appear healthy to try to get a sense of just how many people are healthy but already were infected, or thought they were healthy but are actually asymptomatic carriers. But we're pretty sure that it's anywhere between 10 and 100 times more than the cases we know about. Now, what that means is there's a lot more COVID around than we realize, but it also means that for the vast majority of people, COVID-19 is not a problem. What's really bothersome for us all is that it is a problem in a small minority. We've all heard about the risk among the frail and the elderly, for example, in nursing homes, but also among a subset of people who might be in their 50s or 60s, people like me, who I can ask myself, am I one of these people who, if I got sick, I would get very ill with it? And so even though the chance is low, that's part of what drives the fear here. But for example, it's almost certainly the case that the US may end up having less than 100,000 deaths from COVID-19, which sounds terrible, but is dwarfed by the number of people who die from pneumonia every year in the United States. So,
another question that has come in along that line, if you don't mind, is what's the likelihood of resurgence? The warm weather comes, maybe it tempers down, and then it comes back in the fall. What's the thought process on that?
Right. So what we think is going to happen is we're not going to banish this disease. The disease won't go away. But what we're wanting to do is to get it down to a very low level. And I actually think all of Western Pennsylvania is likely to be very close to a low level already. And then when you have that, think about it as then it's like living in a very arid climate where you're at risk of forest fires, and you just have to have a really good fire suppression system. So I totally think that we could have a resurgence in the fall. It could also just be that we constantly are at risk of waves for really 2 or 3 years until we get an effective vaccine. So people should not be thinking, oh gosh, won't this just go to zero? It will go to very low, but not to zero. And so then everything becomes about running an effective fire suppression system. In other words, let's say we get down to green, as the governor is calling it, and we're pretty close to being green, then we just have to have really active surveillance. And when anyone turns positive, immediately do contact tracing to find all the people around them. And that's like that fire suppression system, putting out little brush fires immediately. As long as we do that, then there will still be people who get COVID-19. The vast majority will do fine, but a small proportion will get sick, and that's why we still need to work on new treatments. But we should, with a real investment in jumping on cases, we should be able to start safely reopening and getting back to what I would call the new normal. The new normal is we probably all will do a little bit more social distancing. We're definitely going to look at more telemedicine use instead of person-to-person contact for some of our frail populations. We have to really think about being careful about screening people clinically and with swabs when they work in nursing homes and so on. But under that slightly more careful way, we can absolutely get back to reopening and getting back to normal.
Thank you for that. And another question coming in, and we'll give you a chance to get a glass of water. Or just a little sip of water, and you can take this too. But Dr. Greg Beard, if you are on, one of the questions coming in is really describing the difference between essential and elective surgery. So, Dr. Beard, if you could field that one.
Yes, I am on, and thank you, David. Thank you, Boo, and thank you, Derek, for providing this opportunity for the community to discuss what's going on. So as we talk about the difference between essential surgery and elective surgery, basically this is just terminology. What we have to do is we have to get back to the business of caring for patients and caring for our community. We know that there are certain procedures and certain cases and certain disease states that can potentially be delayed and to some degree put off. As Dr. Angus had mentioned, it's important from the standpoint of telehealth and those types of processes to continue to keep in touch with our patients. But we do know that there are patients out there that are frail and that are having more and more medical problems as we've been trying to cohort away. Additionally, we know that heart failure and COPD and asthma and diabetes and hypertension and strokes continue at the same level they did before the COVID pandemic. So therefore, we still have a responsibility to care for those patients who have those disease processes. Some of those disease processes require surgical procedures, some of them require interventional procedures and processes that will help them from becoming sicker, will decrease the risk of hospitalization and decrease the risk of complications from those disease states. Anecdotally, for instance, we know that we do a certain amount of cardiac catheterizations at this institution on a daily and a yearly basis. Those cardiac catheterizations are to diagnose, evaluate, and potentially treat patients who have heart disease that may lead to myocardial infarction or heart attack. Over the weekend, we did see 2 patients who had myocardial infarctions or heart attacks that had previously been scheduled for quote-unquote elective catheterization. But because of the moratorium on doing elective procedures, they were temporarily postponed based upon the potential that over a short period of time, they might not have problems. These 2 patients did have problems, had to come in over the weekend and get emergency procedures rather than having it done electively. And they did so under the guise of having an acute heart attack. We know from basically national and international studies and the numbers of patients, as Dr. Angus said, are sick versus those who are potentially infected but asymptomatic, that the closing, if you will, of our hospital spaces and our urgent spaces has led to people being concerned about coming to the hospital or potentially delaying being evaluated for symptoms that they felt might go away on their own or hope might go away on their own. So there's been an increase in complications of stroke. There's been an increase in complications of diabetes. There's been an increase in complications for surgical processes such as perforated colons from diverticulitis and perforated appendicitis. In fact, in New York City, there was some data recently out to support that there is about a 6 times increase in the number of folks being or EMS being called for folks at home who have passed at home, not getting medical care. Potentially for A, the fear of coming into hospitals, or B, the inability of the hospitals to manage those cases. And many of those were not COVID related or coronavirus related, many of those were strokes and heart attacks and complications of hypertension and diabetes and things like that. So what we need to do as physicians, as clinicians, as a hospital, are to look at those patients who need care that we had always provided care for. We will be very, very cautious. We'll be very, very protective of our staff and of our patients and of our community, but we do need to get back to caring for patients who need care sooner than later. So I think hopefully that's an explanation for you that makes sense, but that's kind of where we are in the direction we're taking now.
Thanks, Dr. Beard. Appreciate that. And then we'll just take a couple more in respect for everyone's time. But a question came in. I won't read it word for word, but there seems to be complications with blood clotting that people are hearing about. So either Dr. Beard or Dr. Angus, maybe that's something that you might be able to address a little bit as a complication of COVID.
Yes. So it's definitely being reported that there seems to be a higher than usual incidence of a variety of features that would make one think that people with severe COVID disease are at more risk of thromboembolic phenomena, pulmonary emboli, clots, and also in autopsy studies, it looks like the vasculature in the lungs looks like there's a local coagulation problem. So we are going to be formally testing different strategies against that. And we'll be rolling out in the next week or so. We already do a degree of prophylactic low-grade anticoagulation, but we'll be testing different strategies that are specifically trying to target sort of more aggressive anticoagulation to see if that makes a difference. But it's a great question, and we're very aware. Charles, you're muted.
We can't hear you, Boo. Boo, I think your microphone is off.
I was muted the whole time. I apologize. I was muted the whole time. So the question was 5 to 14 days seems to be a number that people are talking about for self-quarantine. Do you see that changing or being something a little bit different? In fact, you came in touch with someone who had COVID.
I think Emily can probably answer that, Derek.
Okay.
Emily, are you on?
I am on. Good morning. As of right now, with travel in terms of the state, we are still seeing a 14-day quarantine if you enter into the state or have had domestic travel outside of the local area. That would likely change with public health guidance and as things phase back county by county, that will be played out. I'm assuming they will publish anything that changes. But right now, there's a difference only in the sense that if someone is positive, the duration of their illness is usually, or home isolation, 7 days from the onset of their symptoms or the start of the symptoms, plus 72 hours after fever has resolved, whichever is longer, and the patient needs to be fairly asymptomatic to return or come out of that home isolation. Quarantine is when you have been at risk and you need to stay in your home without contact with others in the concern that you may develop symptoms. So that is still currently 14 days from last exposure or travel history right now.
And thank you, Emily. And Dr. Angus, if you can stay with us a little bit more, there are a couple more questions that have come in that I think were for you. There are many antibody tests that are now available for COVID-19, but the sensitivities and specificities for these tests appear poor in general, and therefore these tests may be unreliable. Once we have a well-performing antibody test, should all patients and healthcare workers be tested, and what strategy would you use? Try that one.
These are great questions. So most of it actually was just totally accurate, that there's a whole panoply of potential tests. None of them are entirely reliable as of yet. We are working very actively on this. Alan Wells in pathology is looking at a number of candidate tests, and we are As soon as we think we have a well-performing test, then we're totally interested in rolling it out. Now, the next question was then, or the question was phrased as, would we test everyone? That depends. There is going to be value in trying to understand the base prevalence of the disease, but that doesn't need to mean testing everyone. You can do that with stratified sampling in the community. You can imagine some high-risk groups, such as healthcare workers, might be very interested in knowing, do I carry antibodies because I might be encountering patients? So there will be then targeted groups who may well want to do the test. One caveat is going to be what we learn about the virus over time. So if the virus stays stable, then you carrying antibodies that you could have some comfort level that you're immune to that version of the virus. If the virus begins to mutate or blend the way flu has different strains, then the fact that you are immune to one version of the flu doesn't make you any more protected from getting flu the next year. So there'll still be some learning about the virus over time that will drive the common senseness, if you like, of just exactly how we would deploy an antibody test once we have one we like.
Great, thank you. And then one more for you. Some have said a vaccine within 12 months, and I'm sure that's the question you're getting a lot. So we'll just, any thoughts on a time frame? And I know that's a tough question.
So the real problem with the vaccine, what's happened really quickly is we've got into humans at an incredible rate. So Oxford started running a phase 1 trial yesterday, where it's starting to go into humans. And as you know, UPMC has a couple of nice candidates from Paul Dupre's lab and from Lou Fallow's lab, and we are totally looking at trying to get into humans within weeks. Having said that, it takes a long time with many thousands of patients to show A, that it's safe, and B, that you've got it on board with people who then have to wait long enough to then prove that they weren't actually getting infected. So the trials themselves, it's hard to speed up the trials. So even though all the other parts of the process have gone faster than it has ever gone before, no one really thinks that we'll have a vaccine in less than it's still going to be about 18 months. What we may have before then is passive immunoglobulin. So that's like a passive vaccine where you just get manufactured antibodies that might confer 3 to 6 months protection. And we do think that those could be available, at least in large-scale trials for patients to present with COVID-19 this summer, and that will have a shorter timeline than the vaccine.
Great, thank you very much for that answer. So that's all the questions that have come in. We really appreciate the dialogue. Dr. Angus, I'm going to ask you in advance. We do these quarterly with our Hamot corporators. These are business leaders in the community who have been, we call this their hospital. Truly, we're a community hospital and this is their hospital. And if you don't mind, we might ask you back sometime in the summertime when we get together, because having you with us today has really been a gift to us. So thank you very much for joining us. And Dr. Beard and Emily and David, thank you all for joining us. All of you who joined on the call today, thank you for everything you do for Hamot, and be safe out there, and we appreciate your time, and we'll talk to you very soon. Thanks.